Good morning. Our first speaker is Professor Willy Vangu. Prof. Vangu is a chief specialist, full professor, and head of nuclear medicine at the University of the Witwatersrand. And he's also the head of the Department for Radiation Services at the University of the Witwatersrand. I could literally speak for about Professor Vangu for half an hour or even more, but he specifically told me not to make jokes. On the other side, it's an honor for me to present him, but I realized he is the chair, one of the chairpersons when I speak, so I better don't mess around.
Thank you very much, Professor Libaba. So, as you know that this kind of topic, we cannot really talk about it in less than 20 minutes. So I want just first to thank the organizing committee for the invitation. And then what I'm going to do, I'm going just to go through some of the selected items, as you can see there, and see if it can contribute to your daily discussion, academic meeting on the management of thyroid cancer. So as we do not have time, I'm going just to start. So let's look at the first case that I propose for you here as a young man suspected to have a papillary thyroid carcinoma on FNA. After surgery, as you can see in the bottom there, the disease was confirmed and then was multifocal. So if I ask you, the audience, just by show of hands, please don't be shy, who will go for molecular markers? By show of hands, don't be shy. Okay, who will go for hormonal therapy and follow up the patient? Do you manage thyroid cancer patient? Who will give radioactive iodine? Okay. Who will just discharge patient from cancer care? All right, so just based on what we put there, you can see, even though it looks simplistic, but the management is not always straightforward. So since we have something that comes and they call them guidelines, apparently they are there as standard of care. Let's interrogate them and then see what do they tell us, particularly as a nuclear medicine community in the management of thyroid cancer, based on the role of radioactive iodine. First, we have the ATA that tells us that in this category of patient, a selective use of radioactive iodine may be considered, provided that you look at three things. The first one is the risk of recurrence. The second one is the issue that are actually related with follow-up, which is very important in our environment, since we have most of our patients being mobile from one province to another. And the last one, and I think that should be at the center of the decision that we make, is patient preferences. Most of the time, we want to play God and decide for the patient without including them in the management of their own condition. So we have to put it as the center of the decision. And then looking at the amount of activity that one should give, ATA actually set it at 30. So the ESMO particularly echo everything that ATA says, and then there is really not much difference. And we know that the National Comprehensive Cancer Network, which is the body that is the more dynamic in terms of updating all the guidelines almost on a monthly basis, they also talk and go in discuss the role of radioactive iodine, but they didn't go to specifics. And the ETA with Professor Furio Pacini and colleagues, actually, they came to be the first one, at least for the first time, to tell us when not to use radioactive iodine. But in terms of the amount of activity, they just embrace what was put by the European Thyroid Association. A year ago, Ankara Avram from US and colleagues from both sides of Atlantic in nuclear medicine, they published this standard practice guideline where they again accepted or adopted what the European Thyroid Association said, but then they put something very important there. The controversy that is there when the tumor size becomes more than 1 centimeter up to 4 centimeter. What do you do? So it's still a big controversial debate that's continue and will continue for some times. And then one thing different that they've done compared to all the other guidelines, they decided to increase the amount of iodine up to 50 millicurie. And I think they were right, because we started to see in the management that most of the patients that we give 30, they had to come back for more so that they can really achieve complete ablation. In fact, in our own institution, we did a prospective study putting 2 arms of consecutive patients. Either you go for 30 or high activity that we set at 80, and to look at the outcome. After a median follow-up of 24 months, you could see with all these bar graphs clearly there that the higher activity had better outcome. But we cannot talk about the long-term risk like of recurrence, because you'll need a 5 or 10-year follow-up. And we cannot even talk about the risk of death, because you know that the risk of dying from this disease for this category of patient has been well published. It's less than 2%. And if you want to go in terms of absolute numbers, today actually the specific death related to cancer in lower risk is actually less than 1%. With all these figures in mind, Sophie Le Boulet from Russie, Gustave in Paris, and colleagues, they decided to test an hypothesis that not giving radioactive iodine actually was not inferior to giving radioactive iodine in this category of patient. So they've done a randomized study of over 700 patients, and they had 2 arms, one arm having 30 and the other arm having nothing. So they followed them, and then they set a endpoint of looking at the absence of functional, structural, and biochemical abnormality at a 3-year period. This was the characteristic of the patient. Sorry, you cannot go back. So anyway, and we can see there that all of them, there was a T1 lesion. And then the outcome, oh no, come on. Oh, okay, the outcome was similar in both. So they decided to say that you do not need to give radioactive iodine in this category of patient. While we know that you need a period at least of 10 years before we start looking at presence of recurrence or not, the question that we have today in this category of patient, should we stop giving radioactive iodine? So this is the question. I leave it to you. Coming back to our own patients, it was part of the 2 arms of 30 or 80. This one actually benefits of 80 millicuries, and 6 months later we had a good ablation, which is very good for follow-up in our environment. The second case I want to bring is about a 71-year-old patient that was diagnosed with follicular variant of papillary. As this patient was part of the same scheme of 30 and 80, received 30, and comes back, like I said earlier on, still the disease in the neck or just residual thyroid tissue, so we gave 100. After 100, 6 months later, as you can see there, we still have a focus of uptake there. And when you look at the markers there, you can see there is increased thyroglobulin antibodies. Thank you very much. So let me go back again like we've done before. Just look at this. And this patient, please remember, I had a 30 and 100. Still I have uptake in the neck, and this is the marker that you have there. So who will do nothing on this patient? I hope it's going to work. Okay, so this is the marker. Right? Okay, so who will do nothing? Who will go for structural imaging? Who will just follow thyroglobulin? Who will give radioactive iodine? Okay, thank you. So this is just about an exercise so that when you look at it, then you say, let us go and say, what is the place of thyroglobulin actually? So we know that 4 to 6 weeks following surgery, usually we do our scintigraphy so that we can decide on the management. So this period of 4 to 6 weeks is not a magic number. It is based on the half-life of thyroglobulin, which is about 2.5 days, and you multiply it by 10, it gives you about roughly 27 days. So there is nothing mysterious about it when we say we wait 4 weeks, because this is the period that the thyroglobulin will reach a plateau that can become a marker that you can use for either persistent disease or even a marker of metastatic disease. But what is important is actually how do you interpret thyroglobulin in presence of normal scan or scan that's having some uptake. So you must always make sure that you have the TSH to tell you if it was stimulated or not. And again, very important, each and every sample that you send for thyroglobulin, you must ask for thyroglobulin antibodies. Then it will tell you if actually there was any interference or not. But the topic about thyroglobulin antibodies, it's beyond the scope of my presentation. You can read it yourself. But you can still use them to assist you in categorizing actually the outcome of therapy, as you can see in this standard practice guideline. But there were now people start coming and questioning, can we really use the thyroglobulin to say if there is persistent disease or not? So one of the studies that's well known is from our colleague from Paris, Professor Martin Schulberger, and the study was done in 24 centers in France, and then they found one thing, that regardless of the level of the TG, if it is not above 10 nanogram per ml, the outcome is always the same. It's only when the TG is above 10 that was associated with persistent disease at a median follow-up of 5 years. So they decided to say that if you have a TG post-op of more than 10, this is where you may consider giving a higher radioactive number. So coming and adding to the debate, Roger Shaw actually and colleague, they look at this meta-analysis of over 9,000 patients. And only 2 messages that I'm going to give you from there. One, thyroglobulin may not be a good marker on patients that had partial thyroidectomy. And secondly, if patient had actually a total thyroidectomy, they said that you can use a cutoff between 1 and 2.5 to decide on presence of persistent disease or even metastasis. But the level of evidence is so low here that we'll need actually prospective and big studies to decide where do we go and where do we put this threshold cut. Coming back to our own patients, so we gave 150 and we can go home and be happy because now we have a clear scan with, you can see, almost undetectable thyroglobulin. So the message as we are talking about thyroglobulin here, just look at this from that same patient from we started in the beginning. The message here is that thyroglobulin antibodies, usually they behave like stock market. So you should always watch them and look at their trend. There's nothing, no reason to panic and to act quickly. So if the ups and downs of thyroglobulin antibodies give you some heartburn, please swallow some anti-acid tablet, you feel free. Okay, so this is the message I wanted to give you. So the last case, so that we'll finish on time, it's a young patient. As you can see in the bottom right there, it was diagnosed Hurtle cell carcinoma. So from the purpose of this meeting, what is new, I brought this one only to give you a message. The message is that in the 5th edition of the WHO classification, oncocytic carcinoma was listed as a separate entity, and they discourage us from using the terminology of Hurtle cell carcinoma. However, every time that your pathologist tell you there is an oncocytic, must also give you a morphological differentiation of what you got, because of the prognosis of one of the entity will be worse. In the left, when you have the differentiated oncocytic, the only thing you see, more than 75% changes of oncocytic cells. On the right-hand side, then you're gonna start seeing there is mitotic activities and you see some tumor necrosis. And the differentiated one, they behave poorly. If you look at this univariate study looking at the cumulative incidence of recurrence between the two, there is no match. You can see it. Even the policeman will tell you the blue curve is going so high. You can see it there. And then talking about radioactive iodine, as we put it at the beginning, that was the center of my presentation as well. Radioactive iodine does not have a place in oncocytic type, period. So I'm going to stop here, and in this special Women Month, I would like to recognize the role of women in this audience, and I would like to recognize their role through this photo that was taken on the 5th conference of Solvay in physics. This conference took place in Leopold Park in Brussels in 1927. As you can see there in this photo, there is only one woman. I'm sure you spotted her, Marie Curie. 17 of these 29 posing in this photo, they will become Nobel Prize winners. Marie Curie was the first woman to receive a Nobel Prize, was the first person to receive a Nobel Prize twice, and was the only person to receive a Nobel Prize in 2 different fields of science, chemistry and physics. Both of them today are core of what we passionately call nuclear medicine. I hope that the few remarks that I put in the 3 examples that were enough to cross your blood-brain barriers. And some of you here, during the rest, the pause, will come and testify to me that they managed to have cortical thyrotoxicity. I thank you.
Thank you very much, Professor Vangu, and thank you for keeping to time.